I'm curious though, we weren't able to get a biopsy, and we have a therapy that can target, if a mutation is found. And let's assume you did the liquid biopsy and it was negative. He has an upper tract tumor, FGF alterations reported in about 35%. I'd like to ask Gordon, is there anything that you can do in the urology clinic that would get tissue on this type of patient? Let's assume there's still some tumor up there in the renal pelvis.
Well, so assuming he has residual disease in his...
It would be contralateral. So his renal pelvis was resected years
so it
ago.
was resected. Okay.
But that is in the bank, right?
Yeah,
that
it's
is
in the bank.
Or go for the...
We can go for the tumor, obviously, in his bladder and kind of resect that. The challenges are whether that's reflective of his, genetically, whether that's reflective of his original tumor or not. We'd have to kind of assume that it is, but certainly assuming from performance status and a desire perspective that he was willing to undergo that procedure, I think it's very reasonable to try and get tissue there to send. If you happen to have a target, then you can have that discussion with the caveat that might not be exactly reflective of what his lung disease represents. Nonetheless, I think it's reasonable and may also mitigate any local symptoms he has as his disease progresses over time.
Do you think that tumor that occurred more recently in the bladder, could it be related to the upper tract tumor, perhaps some type of implant in the bladder?
Yeah, so the most common site, obviously, of upper tract recurrence, is the bladder. That can occur in up to 50% of patients over time. That's why we surveil the lower tracts routinely in this patient population. It could be. That's why we would sample it, and that would be the kind of the intellectual kind of connection that we would make, assuming this showed something that was FGFR, positive or PD-L1 positive, et cetera, to justify the use of different agents in this patient who has somewhat limited options.
Mm-hmm. So let's assume you couldn't get enough tissue in the bladder, there wasn't much left. What about going back and looking at the renal pelvis? Especially if we think this could be an implant to the bladder from the renal pelvis tumor and somehow genetically linked. Do we think that could be causing the MET maybe, or?
I mean, I guess that would be sort of down on my list of options, but certainly before saying, there are no more options for you, we would send that. Mm-hmm. I guess my thought is that the lung mets may grow further and become better amenable to biopsy, again, assuming the patient can go for a biopsy procedure or a TUR procedure to get additional tissue. Clearly, the least risky procedure would be to just pull that upper tract tumor from the bank and send that. So it's something we could do. And then liquid biopsy is something we'll pursue as well. Yeah.
So I'd like to explore a slight twist on this case. Mm-hmm. What if this patient not only had congestive heart failure, but also had type 2 diabetes with poorly controlled hemoglobin after failing immune checkpoint inhibition? Would you have still used enfortumab vedotin in that patient?
So that's a great question, and you touch upon sort of one of the mysteries of enfortumab vedotin, which is that, it's an antibody-drug conjugate. We think, the side effect of neuropathy is expected with MMAE. It's a neurotoxin. But there have been issues with diabetic patients having bad, sometimes sort of fatal side effects, or related or unrelated on treatment. And so the study was amended to limit enrollment of exactly the patient you described. So I think, where we are with enfortumab vedotin right now is we have single-arm trial data. We hope and expect accelerated approval to come within the year. But the randomized and larger trials, I think, will answer these questions around who's a candidate. For now, I would play it safe, and the answer would be no. I don't think I would have recommended the patient, and he wouldn't have been eligible for the trial with that.
Yeah, and there is a expanded access protocol now for enfortumab vedotin, and we are one of many sites in the U.S. that are opening the expanded access protocol. I do think it's a very active agent for our refractory patients, and so short of the poorly controlled diabetic patient and other patients who have neuropathy, I would certainly consider it for patients who are progressing past the standard lines of therapy. Mm-hmm. I think it's a good option for until we have approval in this space.
Mm-hmm. So We have two promising drugs. We have erdafitinib approved. Let's assume we have enfortumab approved. And again, both have about a 40% objective response rate and then a median overall survival, which shouldn't be compared, but that seem comparable. Erdafitinib about 13.8 months, and enfortumab about 11 months. You have the same patient failing immunotherapy who has an FGFR3 mutation. Which would you choose?
It's a hard question, Arlene. I think it requires a conversation that you have with the patient, right? So when they have the driver mutation, so that's great, and then you have the options. So do they want to do the targeted small molecule inhibitor first, or do they want to do the enfortumab vedotin? I think it's really hard to distinguish them from an efficacy standpoint. I think we can talk about them from a toxicity standpoint and see if there are any differentiating factors on side effect profiles. But it's a good thing, problem to have, right? And we could potentially sequence these therapies and do one after another. The good news is that enfortumab is not selected for Nectin-4 positivity, and you do have these options to talk through.
Yeah, I mean, I think just convenience is something that then will come into play. A pill is a lot more convenient than almost weekly infusions, which enfortumab requires. So, and again, I think it's such a fortunate position to be in to have these choices, and the decision isn't either or, but which first, hopefully, and hopefully the patient can have the opportunity to achieve benefit from all of these.
I think that's such a great point, Betsy. I've been asked, so you have two options. Which do you give? Which option wins? And the response is the patient wins. Because while people still think about who wins second line, who wins third line, the truth is if you build better treatments and treatments that are more tolerable, patients will then be available to go on additional lines of therapy. I mean, remember the old prostate cancer days before taxanes were approved, and once it was single agent taxane, everyone said, okay, we're done with prostate cancer. There'll never be anything following taxane because it will be just that toxic. But look at how many lines of treatment have evolved now for the therapy of prostate cancer. And we're seeing the same thing evolving in bladder cancer with these new and better agents, and maybe even an ability to avoid the toxicity of chemotherapy altogether. So I think it's certainly a very exciting time for the treatment of our bladder cancer patients who are really the winners in this scenario when we have multiple strategies and perhaps multiple combinations approved down the road. I would like to give a huge thank you to Betsy and Tien and Gordon for their time, for their thoughtful case presentations, and lively and informative discussion. To our viewing audience, thank you for joining us for the Targeted Oncology Virtual Tumor Board presentation. We hope today's discussion was a valuable use of your time and that you acquired some practical knowledge that you can take back to your clinic.